Hello students, welcome to the channel. I'm the OG Guru Dr. Punit Bhojani here, and in this very important video, we are going to discuss the 10 most repeated MCQ topics and MCQs for OBGY for the upcoming FMGE examination. Do share this video with all your friends and colleagues, and I'm here with a single point agenda to make OBGY your most favorite subject and most scoring subject. And those who haven't yet downloaded the app, quickly download the OG Guru app and get in touch with me for your personalized timetable and guidance. I'm guiding all the students how to study, how to prepare. So do drop in a WhatsApp on this number. Let's begin. It's going to be a very important video because these are most repeated topics in OBGY. So you will also get to know the name of the topic so you can prepare which topics, the top 10 most, and also prototype MCQs of every topic we are going to discuss in this MCQ discussion video with the names of the topics. So moving on to the first MCQ or the first topic for the day, and that is anti-partum hemorrhage, APH. So now can anybody look at the clinical case-based scenario and tell me the diagnosis? Okay, 34 years old pregnant lady admitted in view of painless bleeding, BP normal, hemoglobin okay, uterus relaxed. Very important clue. Head floating, fetal heart rate 140. What is the next line of management? So keep in mind, my dear student, that whenever we have bleeding in the third trimester, T3 is the third trimester, what are the two most important points you will keep in mind? Sir, one is placenta previa and second is abruption. Now, extremely important, short MCQ. This comes every year. Can anybody tell me? Yes, placenta previa is a painless bleeding. Abruption, keep in mind, it is painful. I am giving you clues which will be there in your question paper. And you'll remember me on the day of the exam is my guarantee. So placenta previa is painless bleeding. Abruption is painful. Placenta previa, the uterus is generally relaxed. And abruption, you will see either pain, tenderness, and you will read the word tonically contracted uterus. If anywhere in the question paper you read it is tonically contracted uterus, blindly you can mark abruption. Third important difference, okay, sir, the placenta in the lower segment prevents the baby's head from coming down. So generally the head is floating or also unengaged. So all these, that's not the thing over here. It may be floating, it may be engaged. And very important, can anybody tell me what is the very important etiology for abruption? Yes, hypertension and preeclampsia will contribute to abruption. So initially, if the blood pressure is high, ध्यान से सुनेंगे, in the question paper if they tell you BP is 180, 110 or 140, 100 and now the patient starts bleeding, think of abruption because hypertension or preeclampsia is a major risk factor for abruption. That's not the case over here with placenta previa. So most of the time in placenta previa, the blood pressure is normal to begin with. Of course, when there is placenta previa and lot of bleeding and shock, then the patient's blood pressure will drop. But initially in the history, they will say that the blood pressure is normal. Here the blood pressure would be high because that high blood pressure can lead to abruption. Okay, so with this as the clues, now can anybody clap if you feel happy? So easy it has become. Yes sir, painless bleeding, first clue. BP normal, first clue. Uterus relaxed, all the clue, and head floating. You cannot go wrong. What is our diagnosis? The diagnosis is placenta previa. Now, please pay attention and look at the question paper. Placenta previa mein remember how is the delivery going to happen. Placenta previa, look on the board. Baby placenta फाड़ के बाहर नहीं आएगा. फटा placenta निकला hero or heroine. Isn't it? So baby cannot perforate through the placenta and come out. So placenta previa, the delivery is always by cesarean section. Hold on, that's not the answer over here. But remember this, that in placenta previa, whenever I have decided that I am going to do the delivery will always be by LSCS. When will you do the LSCS is important now. Now please understand this. In placenta previa, I can wait and watch, I can give tocolysis. And all of you do comment in the chat box, what is that regimen called? Okay, what is the regimen which I call when I do conservative management in placenta previa? I'm giving you a clue, MJ. Not Michael Jackson. MJ kya hai? MJ regimen, that is wait and watch or conservative. Now look at the question paper very carefully. First of all, when I want to wait and watch in placenta previa, anybody, what is the purpose of waiting and watching? The purpose of waiting and watching is for the baby lung maturity. Okay, is it clear to all of you? But when I want to wait and watch, three conditions have to be satisfied, isn't it? So all of you look on the board. Okay, sir, first when I want to wait and watch, obviously the mother should be stable. Yes or no? Otherwise, what's the point of waiting and watching? For the mother to die? No, फिर wait नहीं करना है. So mother should be stable. Look at the question paper. Yes sir, hemoglobin 11 gram, BP 120, 70. So mother is stable. Second, sir, even the baby should be stable. There should be no fetal distress. And that is the clue, sir. Here fetal heart rate 140 is normal. So there is no fetal distress. And most importantly, sir, we will wait if the pregnancy is less than 36-37 weeks, then only wait and watch. And that is our patient over here, 34 weeks. So in obstetrics, always weeks of gestation is very important. So yes, I have a patient of placenta previa, which is my diagnosis, but we are only 34 weeks. Placenta previa is 34 weeks. Mother is stable. Yes, baby is stable. So I will wait and watch. I will wait and watch, which is the answer over here. Okay, clap if you feel happy, even if one word of the MCQ changes. If instead of this 34 weeks, if instead of this 34 weeks in the question paper, the question is 37 to 38 weeks. Now what does the answer become? Now, so there is no point waiting, and in placenta previa, I will go for cesarean section at 37 weeks. Is it understood? So like this kind of nuances, till the time you listen to my lecture, you cannot get all this MCQ correct, is my guarantee. And for all those who have even recently joined, in last few days, so many students have joined and are enjoying the rapid revision course, will be able to answer all these questions. And my guarantee, students, do all of you subscribe to rapid revision, and when you will walk out of the January FMGE examination, you will message me like every year, sir, among all 19 subjects, my best performance is in OBGY. So same thing will happen with you when you listen to my rapid revision course. Among all 19 subjects, your best performance will be in OBGY, is my guarantee. So coming back to the topic over here, okay, sir, at 37 to 38 weeks, there is no point of waiting and watching. At conservative management will not be done, and the answer becomes LSCS or cesarean if the patient is 37 weeks. Okay, but since we are only 34 weeks, all the three conditions, I repeat, look at the question paper. Mother is stable, baby is stable, there's no distress, and pregnancy is less than 36-37 weeks. So the answer is wait and watch. And please never even think of forceps delivery, is never possible. And similarly, induction, if you induce labor in placenta previa, you will have to go to jail. You have to go to jail, means the patient will bleed to death. So induction of labor also we are never going to do in placenta previa. So placenta previa, the delivery, remember this, the delivery is always by LSCS, but when you touch 37 weeks. If I can wait and watch, at 37 weeks we plan the delivery by LSCS, or before that if there is fetal distress or mother is in shock. Your mother is also stable, baby is also stable, there is no fetal distress, and we are only 34 weeks. So we can definitely do wait and watch. We admit the patient, give her bed rest, steroids, tocolysis, and steroids are given for lung maturity, and wait. That is the answer over here. Clap if you feel happy. And as I said, you'll comment in the chat box, what is this wait and watch management in placenta previa called as? I've given you the clue already, MJ. Okay. Moving on to the next important topic where surely you get the MCQ. Topic name I'm giving you afterwards because I don't want to reveal the diagnosis. Again, a clinical case. Nowadays, FMG, lots of clinical cases are coming. Okay, I have got a lady. She's married, fine, come with acne and hirsutism and also irregular periods. Can anybody think of the most common condition where we get irregular periods also, acne, hirsutism also? Yes. Okay, and one more thing, look at the levels. LH is 15, FSH is 5. Okay, so if you see, sir, in normal patient FSH to LH 2:1 is the ratio that is normal. And in what is my diagnosis? Yes, PCOS. So that's the next important topic, hot topic. Every year questions generally are coming from it. In PCOS, the ratio becomes inverted or ulta. In PCOS, this ratio could be 1:2 or even 1:3 or even 1:4. Okay, so 2:1 is normal, and in PCOS the ratio becomes ulta. Here you can see LH is 15, FSH is 5. So the ratio in the question paper is 1:3. So everything points to the diagnosis of PCOS. Why? Sir, acne, hirsutism, irregular periods, FSH LH ratio altered. Those are the clues. They can also say on sonography, necklace of pearl pattern. Now, what do you think is the best treatment for the condition? Student directly PCOS question padta hai and marks clomiphene, letrozole. No, please understand this. Clomiphene and letrozole will be the answer when I'll tell you. Now, please understand this. In PCOS, always the treatment will depend on what the patient wants. If the patient says, doctor, I have infertility or I am planning pregnancy, one word answer. Why is there infertility? Because of anovulation. In PCOS, there is anovulation and therefore there is infertility, and then the management becomes ovulation induction, and that is the time when I go for letrozole and clomiphene citrate. Those are for ovulation induction. And again, comment in the chat box as per the latest guidelines, which is the first drug of choice for ovulation induction in PCOS patients. Do comment, I'll give you the answers as per the latest guidelines. What is short MCQ? What is the first drug of choice for ovulation induction in patients of PCOS? But that's not the question over here. Here patient says, doctor, even though I am married, I don't want infertility treatment. I want treatment for acne and hirsutism. So when the patient says that, sir, right now give me treatment for acne, hirsutism and my irregular periods, what do you think is the answer? Yes, clap if you feel happy. ठोको ताली, नाम में ही आंसर है PCO, उल्टा कर दो OCP. Nobody will teach you like this, is my guarantee. PCO, OCP. Isn't it? They are made for each other. So OC pills is the answer. Even if you know this much, this is excellent. One step further difficult, virgin MCQ. So please understand this, that here we are going to go for OC pills. But specifically, which OC pills helps in PCOS? Yes, sir. Cyproteron is a progesterone with a anti-androgenic property. Clap if you have learned something new. So, sir, in PCOS patients, sir, LNG can cause slightly more acne. So, I don't prefer OC pills. OC pills is correct, but with LNG, levonorgestrel, I don't prefer. Okay, because LNG can cause slightly more acne. Remember this new thing, that's a cyproteron is a progesterone with a anti-androgenic property, and that becomes the answer when the patient of PCOS complains of acne, hirsutism. Is this understood? So very important MCQ. And remember this, that sir, the treatment always depends on what the patient wants. If she wants treatment for acne, hirsutism, answer is OC pills. If she wants infertility, ovulation induction, yes, of course, without fail, weight loss, diet, exercise, lifestyle modification, very important. And even don't forget metformin. Metformin is a insulin sensitizer, very important in PCOS patients. So weight loss, diet, exercise, and OC pills, but OC pills with cyproteron. Okay, clap, PCO, OCP. Lifelong you will not forget, my guarantee. Okay, next extremely short hot topic, primary amenorrhea. I hope all of you know the new and the latest definition of primary amenorrhea. 14 years and 16 years are the old definition. The latest definition is 13 years and 15 years. Okay, so this is a very important change in the criteria for PCOS. I hope you get it correct. Okay, now what is the question over here? We have got a patient, primary amenorrhea, breast well developed, very good, absence of axillary pubic hair, some lump in the inguinal region, what it is, and ultrasonography, absent uterus. Now my dear students, again remember this, that whenever I get a MCQ of primary amenorrhea and absent uterus, primary amenorrhea and absent uterus, lifelong, only two conditions are possible. You will not even look at option 3, option 4. Whatever may be the syndrome name, Turner syndrome, Kalman syndrome, XYZ syndrome, Klinefelter, whatever any name of the syndrome may come, it is not possible to have any other thing other than these two. I repeat, primary amenorrhea, absent uterus, whole of gynac, only two possibilities. One is RMKH, Rokitansky, Mayer, Kushner, Hauser, also called as Mullerian agenesis. Mullerian duct does not develop. And second is androgen insensitivity syndrome, complete androgen insensitivity syndrome, also called as testicular feminization syndrome. So itna hi yaad rakhna hai, primary amenorrhea, absent uterus combination, only these two things. So automatically the Turner syndrome, Kalman syndrome out. Why? Because the Turner syndrome, the uterus is present, and similarly even in Kalman the uterus is present. Okay, do comment in the chat box one what extra feature in Kalman syndrome patient will have. Okay, I'm giving you a clue. Okay, what extra feature Kalman syndrome में होता है, something to do with the nose. I'm giving you a clue. Okay, now आगे देखो. So primary and absent. Now breast is not a difference. The breast is well developed in both these patients. Both these patients, the breast is going to be well developed. But as the name suggests, sir, androgen insensitivity, what are we going to examine? Look at the patient's axillary and pubic hair. In a patient of RMKH syndrome, please understand this, even in girls, the axillary and pubic hair is androgen dependent. So in a patient of RMKH syndrome, the ovaries will secrete androgen, adrenal glands will also secrete androgen, and here axillary and pubic hair is well developed. But in a patient of androgen insensitivity, sir, androgen cannot act. Androgen, testosterone is there, but testosterone is nikamma. Testosterone cannot act. And therefore here, sir, the axillary and pubic hair is going to be absent or even sparse. Okay, so please look at the hair. Hair means not here. Look at the hair in the axillary and pubic area and you will get your diagnosis. And now anybody, breast well developed, very good, but absence of axillary and pubic hair, the diagnosis is androgen insensitivity syndrome. That is the diagnosis. So every year short. And can anybody tell me what is the lump in the inguinal region? Yes, sir. That lump is the undescended testes. Okay, undescended testes, because these patients of AIS have got testes. Okay, is it understood to all of you? Similarly, just if I change one word, if instead of absence I write axillary pubic hair well developed, now what is the answer? So see how one word question change, answer change. Clap if you feel happy. So sir, if axillary pubic hair is well developed, my answer becomes now RMKH. Okay. Is it understood to all of you? So this is just to show you all the variations in the question. I'm just making the question paper back to the original question what we had made, so there's no confusion. So sir, absence of axillary pubic hair, answer is androgen insensitivity, because in RMKH there is the axillary and pubic hair is well developed. I'm writing plus plus plus. Is this understood to all of you? And very important, can you tell me the karyotype also? Yes, sir. In RMKH, the karyotype is 46XX, and in androgen insensitivity, the karyotyping is 46XY. Okay, so I remind you, do comment in the chat box what one extra or special problem patients of Kalman syndrome have. Okay, something to do with the nose. Okay, so short topic, primer amenorrhea, absent uterus, or overall primer amenorrhea. Every year the question comes. Also cryptomenorrhea questions are very important. So all these other topics based on this, surely you're going to get the question in your upcoming FMG examination. Again, a short topic, trisomy 21 detection. Now here, my dear student, the important point is certain tests are the screening test. Please remember these. Okay, you can check the video. Screening test is your double marker, triple marker, quadruple marker test. And the confirmatory tests. What are the confirmatory tests? Please understand that one is the screening test for antenatal trisomy 21. The confirmatory test in the whole world is karyotyping. Karyotyping is confirmatory test. How can I get the sample of karyotyping? Yes, sir. Karyotyping can either be done by chorionic villus sampling or by doing amniocentesis. Now let us see what the question is. Image based question. Clap if you feel happy. Okay. पिक्चर दिया आपके सामने. This procedure can be done at what weeks of gestation for antenatal trisomy detection 21, antenatal detection of trisomy 21, or for confirmation. So what is this? If you see, if you look at the picture carefully, so uterus, baby, a needle is poked and the needle is in the amniotic pocket, and I am taking out the amniotic fluid. Isn't it? We are sucking out the amniotic fluid. So the procedure name is amniocentesis. Again, this image has been asked. And my dear student, when is amniocentesis done? Yes, sir, in the second trimester after 14 weeks. So generally 16 to 18 weeks or 15 to 18 weeks is the best answer over here. I don't do it in the first trimester. And yes, 36 to 38 weeks पे भी अगर हम needle poke करते हैं और निकालते हैं amniotic fluid, that's also amniocentesis, but that's done at 34-35 weeks in third trimester when the patient has severe polyhydramnios and breathlessness. So mother cannot breathe and severe polyhydramnios. Then you can think of doing. Here it is clearly mentioned that amniocentesis for trisomy 21 detection, I have to do between 15 to 18 weeks so that I can get the diagnosis by 20 weeks. So that if the patient has got Down syndrome, we can take the further steps of going in for termination and MTP. Okay, so amniocentesis, remember, is done in the second trimester. So, and one more important question. So, screening test, confirmatory test, the screening test, chorionic villus sampling is done in the first trimester. T1 I am writing. Amniocentesis done in the second trimester. Okay. And one more important point, since we are on the second trimester confirmatory test, in second trimester, we do the triple marker test and the quadruple marker test, and they are also done between 16 to 18 weeks. Is this understood to all of you? So if the question paper is name the screening test done at 16 to 18 weeks, triple marker, quadruple marker. So many extra information. And name the confirmatory test done in the second trimester. Yes, sir. Amniocentesis and karyotyping is a confirmatory test. So in the picture, we have an ultrasound guided baby, and ultrasound guided, we are poking in the needle into the uterus through the transabdominal route. We are sucking out the amniotic fluid. The process is amniocentesis. Okay, so moving on, again a short hot topic, infertility. One question comes for sure in infertility, lot of things, tubal testing, male factor, female factor. So let's see what our Question is 29-year-old lady, infertility, history of dyspareunia, dysmenorrhea, uterus retroverted with some nodularity in the pouch of Douglas. Next best investigation to be done. First diagnosis. Anybody? Yes. ध्यान से अगर आप क्वेश्चन देखते हो, what has the patient come to us with a triad of DID? DID is what? Dance India Dance. That's how you remember. DID is dyspareunia, pain during sexual intercourse, dyspareunia, dysmenorrhea, painful menses, and infertility. Is it clear? DID understood? So dysmenorrhea, dyspareunia, infertility. That is classical of endometriosis. Very hot topic. Recently MCQs have started coming on this. Okay. Now, please understand this. And again in endometriosis, because of the adhesions, because of all the adhesions, the uterus becomes retroverted and fixed. That is because of the adhesions which are present in the pouch of Douglas. Adhesions in the pouch of Douglas, POD, will cause the uterus to become retroverted, and nodularity also you feel. Now, what is the best investigation for endometriosis? In short is the question. Now, please understand this. Endometriosis mein we have chocolate cyst and lot of other endometriotic implants. Please understand this. HSG no role. HSG is going to tell us about the tubal patency. That's not the problem over here. Okay, the best investigation. Similarly, sir, hysteroscopy no role. We're going to discuss hysteroscopy later on. Okay, it's to look at the cavity. Now, please understand, yes, sir, sonography can be done. Sonography can pick up a chocolate cyst, but sonography can also be normal in a patient of endometriosis. Why? Because, sir, endometriosis, seeing is believing. Laparoscopy is the best investigation or the investigation of choice. Why? Because in laparoscopy, we can see the endometriotic lesions. They are called as the endometriotic implants. How they look also I tell you. For the endometriotic lesions we can see with our own eyes. And the advantage of laparoscopy is not only diagnosis, simultaneous treatment or surgery can be done with the laparoscopy. So can anybody tell me, if I put in a telescope, laparoscope is the putting in a telescope through the anterior abdominal wall, what all will I see? So this is the uterus, this is the uterosacral ligament, this is the fallopian tube. So lifelong you will not forget. Yes, anybody quickly can you tell me, in a patient of endometriosis, what all do I see? Okay. Yes, point number 1, sir, inside the ovaries, we will see chocolate cyst. Okay, so like black, brownish, blackish. Okay, assume this is just a chocolate color, thoda sa more dark. Okay, so you will see a chocolate cyst in the ovary. What else? Anybody, what else can we see in endometriosis? Yes, so there could be adhesions between the tube and the ovary and adhesions in the pouch of Douglas. And the famous, yes, matchstick burn spots. So in the area of this uterosacral ligament, gunshot appear and they are like black spots. Okay, so matchstick burn spots. Okay, matchstick burn spots or gunshot or gunpowder appearance or powder burn appearance. Okay. Okay, and what else? Okay, what else? Yes, all the fruit salad. What do I mean by fruit salad? Sir, blueberry, red raspberry, red strawberry. So you get this red color, ke spots. They are like your raspberry and strawberry red color dots. We also get purple. Okay, blueberry, raspberry, purple. So it's like a very colorful picture. And lastly, don't forget our favorite color blue, the blue color. Okay, so can you see all this? तो ये सब जो चीजें हैं all these implants cannot be seen on ultrasonography. We will have to do a laparoscopy. So laparoscopy will see red lesions, blue lesion, red raspberry, purple raspberry, blue lesions, gunshot appearance or matchstick burn spots. So laparoscopy is the investigation of choice. Laparoscopy will also see the chocolate cyst, and we can remove the chocolate cyst also. Is this understood to all of you? Okay, so that is how the whole thing is going to be in endometriosis. Very important MCQ. Next important topic, short, contraception, MTP. And can anybody tell me, patient has 45 days of amenorrhea, wants MTP, what will you do? And directly student mark karta hai mifepristone, misoprostol, and they mark the first answer. No, please understand this. Very important. First of all, the medical method. Medical method is allowed up to 9 weeks. Okay, up to 9 weeks or 63 days, we can go with the medical method. Now, the medical method, all of you look on the board, my dear student, is like a combi kit. It is like a combi kit. There is a single tablet and there are 4 other tablets. Now, what are the tablets? How are the tablets, and what is to be taken first, what is to be taken afterwards? Total confusion. Again, clap if you feel happy. मैं हूं ना. First we give mifepristone. कैसे याद रखेंगे सर? First mifepristone has F. F for mifepristone, F for first. So on day one clap, mifepristone, the one which has F, 200 milligram. Okay, so now all of you know, okay, sir, here it is 200 microgram. See, trick. So wrong. And similarly, meso is not given first. So option B is out because यहाँ पे लिखा है misoprostol first and then mifepristone after 48 hours. Misoprostol first and mifi after 48 hours. So that is wrong. Why? Because sir, first we give mifepristone, it's an anti-progesterogenic agent, and after 48 hours on day 3. How? Again you will remember, sir, misoprostol is the second drug. Second starts with S and meso में भी आता है S. Clap. Okay, so F is given first, that means mifi is given first, S is given second, S drug is meso given second. Okay, so this, please understand my student, this is the first tablet, this is of mifi, and this is 200 milligrams. Don't make a mistake. Okay, and then we have got this 4 tablets. What it is? PGE1. What kind of meso is meso? It's what's prostana PGE1. Each tablet is 200 microgram. You can see total 4 tablets, total 800 microgram is the dose. I either give it vaginally or sometimes orally, sublingually also, but vaginally preferred, or even orally and sublingually also. Okay, so the answer is mifepristone 200 milligram. So units bhi dekhna hai, and first, second, misoprostol 800 microgram after 48 hours. Option number C, clear cut, is the answer. B and D are out because meso is there written first, and first, very common, many will make mistake in it, but the units have interchange. This is 200 microgram and 800 milligram. Sorry, that is wrong. That is wrong. Meso is 800 microgram. So short, please keep this in mind, and the question is surely coming. Okay, so mifi first, meso later. One more MTP MCQ just to tell you the recent guidelines as per the latest now. Yes, MTP is allowed till 24 weeks of gestation. But this 24 weeks of gestation is for when? Yes, sir, when there is some fetal anomaly detected or any chromosomal anomaly in the baby, then fetal anomaly, we can do it up to 24 weeks. Or if there's a sexual assault victim or rape victim, then again we can do it. And if mother's life is at risk, of course we can do it. So this 20 to 24 has been extended because certain times the patient comes in late and the anomalies are detected later, or rape victim does not come out of fear, and then she is already 22-23 weeks. But short, remember my students, the important point that sir, failure of contraception is a very important reason why we do MTP, and one of the most common reason that is still allowed only up to 20 weeks. Okay, if the condom has ruptured and the contraception has failed, you can't be sitting at home till 24 weeks. So please understand this, that yes, MTP now as per the latest guidelines is allowed till 24 weeks is the answer. But if they ask you for failure of contraception, the answer is still only 20 weeks. Okay, so for failure of contraception, still it is only up to 20 weeks only. Is this understood to all of you? So please don't make a mistake in this. It's a very important thing. Okay, so 24 weeks is for rape, sexual assault victim, some special circumstances, fetal anomalies, chromosomal, and mother's life is at risk. We go for allowed till 24 weeks of gestation. Okay, so before we proceed further, do not forget to share this video with all your friends and colleagues, and do get in touch with me on phone and WhatsApp on this number. Download the OG Guru app, and within 2 days time, just you can take the rapid revision course. Within less than 2 days time, you will be able to entirely revise the entire OBGY under my guidance with beautiful handwritten notes. We are going to show you also in some time, and you will love the MCQ discussion which we are going to do in the app. Like this only, you will be loving it. Okay. Yes, next important topic, prolapse. Again, very common question. Students, questions are coming on prolapse, and the question what I've got for you is Fothergill repair. All are the complications except. Now, can anybody tell me what is the main step of Fothergill operation? And then you know the answer. So, sir, main step of Fothergill operation is cervical amputation. Okay, cervix bahar aaya hai. Chop off the cervix, cervical amputation. Now, what can happen if I chop off the cervix? Sir, either the cervix can undergo too much stenosis, fibrosis. So, sir, there could be cervical stenosis and patient will have difficulty in conceiving and infertility as a complication. Or the cervix can become too loose and weak, which is called as os in cervical incompetence. And if there is cervix, so either the cervix becomes too tight, cervical stenosis, or cervix becomes too loose, cervical incompetence. And if there is cervical incompetence, my dear student, the patient will have what? Yes, sir. When the patient has cervical incompetence, there could be repeated painless abortions in the second trimester. And that is the important point. Okay, sir, patients of cervical incompetence will land up with repeated painless second trimester abortions and never in the first trimester. And of course, if the cervix is weak, there's also other complications are your preterm labor, PROM, and if the cervix is tight, then during labor, the cervix may not dilate, and cervical dystocia also. Cervical dystocia means cervix fails to dilate. So, infertility, dystocia, cervical incompetence, second trimester abortion, preterm labor, PROM, PPROM, all these are the complications. And now, my dear students, you can easily answer, yes, sir, cervical dystocia, preterm labor, not whenever the fourth option, all of the above, student वही mark करता है, none of the above, except, okay, except option A, first trimester abortion. First trimester abortion causes a different chromosomal genetic patients of Fothergill, and therefore Fothergill operation is hardly ever done nowadays. Is this understood, my dear students? We avoid doing Fothergill for the same reason. And remember, patients of Fothergill will have cervical incompetence, and there is second trimester miscarriage or abortion. Okay. And do comment in the chat box what surgery I do. If the patient has cervical incompetence, and during pregnancy what surgery we do for the treatment of cervical incompetence. Okay, so sir, Fothergill will lead to cervical incompetence and second trimester abortion, and they are yes, painless abortion. And what is the treatment to prevent this? All of you do comment in the chat box. Okay, now moving on, short again topic, pre-eclampsia, eclampsia, very hot topic, and questions are going to come on this for sure. Okay, so let us see the question. 32 weeks pregnant lady, BP 180, 110, complains of headache, oliguria, blurring of headache, blurring of vision, no convulsions at present. What do you think is the best management? Now, what is the diagnosis over here? Anybody? Yes, a normal student will say, sir, the BP is high, 180, 120, albumin plus 2. Normal student will say, sir, this is preeclampsia, or they might say severe preeclampsia. No, but my students, please understand this. There are some dangerous symptoms mentioned in the question paper. What are those? Yes, sir, headache and blurring of vision. Okay, they might also add one or two more to make the question paper slightly easy. And these five you have to by heart it. What are those five? Okay, O, B, easy है ना. OBGYN, OB, easy है ना, because मैं हूं ना. Okay, oliguria, blurring of vision, epigastric pain, headache and nausea, vomiting. ठीक है, so the mnemonic O, B, easy है ना. Okay, है ना? Yes, है ना? Yes sir, आप हैं, हम हैं, तो easy है. Okay, so when these symptoms, these are called as the premonitory symptoms or the dangerous symptoms, and the diagnosis completely changes and it becomes impending eclampsia. Okay, it is not only preeclampsia, the diagnosis is impending eclampsia. This question, okay, sir, patient has not yet got convulsion, no convulsion at present, but anytime she can get the convulsion, so the diagnosis is impending eclampsia. And please understand this, whenever there is impending eclampsia, आपने हिंदी पिक्चर में देखा होगा, डॉक्टर लेबर वार्ड के बाहर आता है और बोलता है हम माँ और बच्चे में से किसी एक को बचा सकते हैं. ओके, लेकिन फिर किसको बचाना है? फिर कोई खड़ूस सास बोलेगी सर बच्चे को बचाओ, लविंग हस्बैंड बोलेगा सर माँ को बचाओ, इंटर्न बोलेगा, डॉक्टर बोलेगा सेव द डॉक्टर, सेव द इंटर्न, इंडियन गवर्नमेंट सेव द टाइगर, सेव द चीता. सो किसको बचाना है? सो प्लीज अंडरस्टैंड दिस कि ऐसा जो ऑप्शन है कि हम माँ और बच्चे में से किसी एक को बचा सकते हैं इज नेवर एवर गिवन टू द रिलेटिव्स. इन ऑब्स्टेटिक्स ऑलवेज मदर फर्स्ट. वाई? बिकॉज अगर मदर है तो पीछे पूरा क्रिकेट टीम आ सकता है. Okay, so mother is more important, and that is why please understand this, that whenever there is impending eclampsia, that is the last day of the pregnancy and the delivery has to be done. I cannot wait and watch. Let the patient be 28 weeks, let the patient be 30 weeks, 32 weeks, 34 weeks, 36 weeks, 37 weeks, the answer does not change. Yes sir, the baby is only 32 weeks. Yes, fine. माँ और बच्चे में से mother is more important. And why do I do the delivery? Because sir, delivery is the definitive treatment for this patient. So never wait and watch in a patient of impending eclampsia. But very important, what will we give to the patient also? Yes sir, magnesium sulfate will be given to prevent convulsion. Yes, so many students know, okay sir, in eclampsia to of course I give Maxelf, but even for impending eclampsia, Maxelf has to be given to prophylactic. This is prophylactic magnesium sulfate. Okay, prophylactic magnesium sulfate will be given. It has to be given. It is life-saving. And again, after giving Maxsulf, we do not wait and watch. After giving Maxsulf, I have to proceed for induction of labor and delivery. Of course, labetalol will be given to control the blood pressure. So we never give phenytoin and immediate LACS. Never. We never only give labetalol induction. Please, you have to choose the best option. And again, this is wrong. Labetalol very good, Maxsulf very good, but deliver at 37. Sorry, sir, patient is only 32. If I wait, mother will die, baby will die. I can never wait till 37 weeks. I have to do immediately labetalol to control the hypertension, magnesium sulfate, followed by induction of labor, which is the answer over here. Why not D is the answer? So D is not the answer because the most important thing, Maxsulf is not mentioned. Okay, यहाँ पे Maxsulf होना चाहिए. Maxsulf has to be given. Why? Maxsulf is life-saving. So remember, student, the purpose of this MCQ, it's a tough MCQ, very likely repeated, will come in the future for sure. So the purpose is that, sir, eclampsia, you give Maxsulf, everybody knows. Here they have said no convulsion. So students say no need to give Maxsulf. No, sir, even this is impending eclampsia. Maxsulf has to be given and I have to proceed for the delivery. Most important words coming in the bracket, irrespective of weeks of gestation. Irrespective of weeks of gestation means whatever may be the weeks in the question paper, 28, 30, 32, 34, answer will not change. You always go for delivery. Induction of labor is preferred first. If any fetal distress, then you can think of LACS, वो सब बाद में, but you can induce the labor first and try for vaginal delivery, but never wait and watch. Okay, so I hope you loved the concept, and as I said, please share this video with all your friends and colleagues without fail, and you also comment in the chat box how you are liking the video. Next important topic, again I've hidden the topic because I don't want you to tell me the diagnosis, I don't want you to reveal the diagnosis. First, patient has come to us with amenorrhea, missed periods, and beta HCG is positive, so pregnancy, but ultrasonography uterus empty. This is your clue. Okay, sir, patient is pregnant, ultrasonography uterus empty, and 2.8 into 3 centimeter left adnexial mass. What is our diagnosis? Yes, sir. Yes, sir. The diagnosis is ectopic pregnancy. Okay, ectopic pregnancy. I will also add a couple of other points in the question that they will say patient pulse 70 per minute, BP is 110/80, hemoglobin is 11 gram percentage. Okay, I have taken the exact MCQ which was there in the PYQ, but this also information they will give you. 24-year-old patient and uterus empty. So now can anybody, yes, remember student that whenever the diagnosis ectopic pregnancy, whenever the beta HCG is positive, and if they say uterus is empty, then you have to look outside the uterus. So uterus empty, and outside the uterus, if I see a adnexial mass, okay, adnexial mass or mass in the tubal area, they say that is your ectopic. Okay, sir, ये beta HCG positive है, so pregnancy तो है, uterus is empty, and this adnexial mass, that mass is the ectopic pregnancy. Now please understand this, that what will I do? Yes, never directly. Please understand this, with the question paper that pulse 70, BP 110/80, hemoglobin 11, this is our unruptured ectopic, because ruptured ectopic patient will come always in shock. Okay, my dear students, so ectopic pregnancy, you have to remember both the scenarios. If it is ruptured ectopic pregnancy, patient is in shock, I have to stabilize the patient and immediate surgery. And if it's an unruptured ectopic pregnancy, what do I do? Yes, sir. For unruptured ectopic pregnancy, methotrexate is the choice, provided 4 criterias. What are the criterias? Sir, patient should be stable. Look at that means it's an unruptured ectopic. Look at the question paper. Yes, they have told you this extra, all this information. Say hemoglobin 11, BP 110/70, pulse 70, so patient is stable. And very important, the gestational sac. Anybody? The gestational sac should be less than 4 centimeter, and the beta HCG should be less than 5000 micro international units per ml. The fourth criteria, they may or may not mention that, sir, there should be no fetal cardiac activity, or fetal cardiac activity should be absent. Even if at your level that is not mentioned, that is okay. So my dear student, if you closely look at the question paper, yes sir, the sac size is only 3 centimeter. So we have got a 3 centimeter patient with an unruptured ectopic and HC levels of only 1800. Answer is there is no need of surgery, methotrexate. Okay, and we prefer to give single dose methotrexate intramuscular route. It's never IV. Okay, never IV methotrexate. Okay, so methotrexate, and you check the HC level should keep on dropping down. Okay, so when the patient is hemodynamically stable, it's an unruptured ectopic, sac size of less than 4 centimeter, and a stable patient and HC levels of less than 5000, please go for methotrexate, which is the answer over here. So moving on to the last very important topic, and that is the topic on Mullerian anomalies and hysterolaparoscopy. Okay, laparoscopy I've already discussed in our previous MCQ of endometriosis, where we see from above, we put in a scope into the abdominal cavity. Now we'll discuss what is hysteroscopy and which Mullerian anomaly are we talking about. Some question on this surely comes nowadays. Bicornuate uterus, septate uterus, very common. So patient has come to the OPD or the hospital with midline septum in the uterus. What is the management of this condition? Now my dear students, what we need to know over here is, okay, how is the septate uterus? Please understand this. It's a septum is going to come within the cavity. From outside the uterus is normal. Outer surface of the uterus dekh ke, ya by looking at the outer uterus, I can never say if there is a septum inside or not. Is this understood? So septum uterus or septate uterus, it can cause infertility, repeated miscarriage, all this. It is a septum which is projecting within the uterine cavity. It is projecting within the uterine cavity. And here, what will I require to do? Yes, sir. We put in a telescope through the cervix into the uterine cavity. Hysteroscopy is to be done. It is the gold standard whenever I have any problem or pathology in the cavity. Here, no point doing laparoscopy. Please understand this. Laparoscopy is the terrace view. You are seeing something from the terrace. So if you go to the terrace of the building, from there you cannot see how many students are in the classroom. Yes or no? If you go to the terrace of your building, from there can you see your bed and your bedroom and all that? You cannot see. You can see? No, you cannot see. Okay, so from the terrace of the building, I can see the roads and the car from outside, but from the terrace of the building, I cannot see how many students are there in the classroom or how many students are there inside the classroom. Is it clear to all of you? So laparoscopy has got no role in management of septate uterus. Important concept. Here I have to go from inside. So hysteroscopy inside the classroom view, laparoscopy outside view. And we go through the hysteroscopy and with the scissors we cut the septum, and that surgery, okay, we have to go and see. I'll show you how it is done, and we have to go like this. You can see, and we are cutting the septum like this. This surgery is called as laparoscopic. Nahi, this is hysteroscopic septal resection. Okay, hysteroscopic septal resection. Septum resection सबको पता है, या also hysteroscopic metroplasty or septoplasty. Okay, septoplasty or septal resection, लेकिन it has to be hysteroscopic guided because it is in the cavity. So now you see laparoscopy, sorry sir, no role. Laparoscopy, as I told you, is endometriosis या बाहर से जो भी देखना है. Okay, similarly laparoscopic resection, sorry, and hysteroscopy is the answer. Hysteroscopy septoplasty or hysteroscopic septal resection is the answer. Is this understood to all of you? So student को पता है हाँ septum है तो septum resection, लेकिन कैसे करना है? Through hysteroscopy. Similarly, can anybody tell me what is this option C? Sir, suppose if I tell all the student कि sir there is Asherman syndrome. Now what is Asherman syndrome? Sir, Asherman syndrome is intrauterine adhesions within the uterine cavity. What will I do? Yes, sir. Again, sir, adhesions, adhesiolysis, but again, hysteroscopic. You can see I'm cutting the adhesions through the scissors. Hysteroscopic adhesiolysis and never laparoscopy. Okay, so ये जो option C है, hysteroscopic adhesiolysis, that is done for Asherman syndrome. 2 MCQs discussed. Okay, so remember my dear student, septum is projecting within the uterine cavity, and for septum I need to go for hysteroscopic septal resection or septoplasty. Asherman syndrome is intrauterine adhesions that also requires me to do a hysteroscopy. Laparoscopy has got no role in management of intrauterine adhesion. Laparoscopy I will do if there is adhesions in the pouch of Douglas, adhesions between tube and the ovary, anything outside the uterus. So when I want to look at the pelvis, we go for laparoscopy. Here please understand this, in septum uterus, in septate uterus, the problem is within the cavity of the uterus. Outer part of the uterus is going to be absolutely normal. It's going to be normal. So there is no role of laparoscopy. I hope you have liked the concept that sir, hysteroscopy is within the classroom. So when I see if all the students are in one classroom, I see all of you, then I am the hysteroscope. But from inside the classroom, I cannot see who is standing on the terrace of the building, and vice versa. Terrace view is laparoscopy view. From the terrace, I cannot see who is inside the classroom. Okay, so laparoscope, hysteroscope, don't confuse. Sure, this MCQs are going to come. Okay, students, so this is very important point. All of you, so many students are joining every day. Please don't miss out in the opportunity. When you start studying, you will realize what you have been missing till now. Students thank me and tell me, sir, so many thank you messages that, sir, we were finding OBGY so difficult. It has now become a cakewalk. It will become your most scoring subject and most favorite subject is my guarantee. And just in 2 days time, just in less than 2 days time, you will be able to master and revise entire OBGY. This is the number to get in touch with me. Download the OG Guru app, and just in rupees 570 you are going to get 1 month package of rapid revision MVP MCQ course and free extension. Don't wait, free extension till the date of Jan 12th FMGE examination. So till Jan 12th your package would be valid. It has got all the previous year question, image based question, clinical scenario, and beautiful handwritten notes, and of course my doubt solving and mentoring is always available. So do subscribe to this as soon as possible, and you will become champion in OBGY and master. And when you walk out of the 12 Jan examination, you will call me and thank me that, sir, among all 19 subjects my best performance is in OBGY, which happens every year. Okay, these are all what the students are saying and telling about the app. And the last thing, look at the beautiful handwritten notes. Complete. The notes are e-version of the notes are included in this rapid revision course. Beautiful handwritten notes, completely colored and easy to learn and easy to revise. And my guarantee, student, once you finish all the videos in less than 2 days, you will finish the video in less than 2 hours. Students have told me that, sir, after we have seen the video, in 2 to 3 hours we can revise the entire notes. Okay, so wishing you all the best for the upcoming examination. Any difficulties, directly get in touch with me on this number. And do subscribe to the OG Guru app, and also please share this video with all your friends and colleagues. Do hit the like button and subscribe to the YouTube channel. Also, many more interesting videos are coming up, and do enroll in the rapid revision course, and you will love the lectures, and OBGY will become your most favorite subject, and most scoring subject is my guarantee. Bye bye, best of luck, students.